Hey guys, hope I'm audible and visible. If so, say me a hi. So, how are you guys doing? Had an amazing Diwali. I hope this Diwali was good and I hope it gives a very colorful and a prosperous year for you ahead, right? Hello, Mukul. Good evening. How are you doing? So, we'll continue our FARRE series. Most of the students wanted us to complete the FARRE series by the December end, and they will be able to revise them whenever they do as per the schedule, right? So, as per your request, we are going to continue with the same FARRE, whatever we have been doing. So, I'll be starting with CBS here. Hello, Neeraj. Hope you're doing good. I'll take about a little bit about your heart and as well as about blood vessels in today's class. The one thing which we missed on Saturday, the RBC and the WBC, I'll definitely cover that at the end of the session because there's an overlap between a live lecture in the app as well as in the YouTube. So there's a mismatch here. Fine. So without any delay, so let's start about going to CVS pathology, right? So I'm sure that you guys must be fresh and with an amazing attitude of after India winning the semi-finals and hopefully in the final also will win. And your exams also will be as colorful as Indian cricket. We hope that. Right? Let's go ahead. And today the topic what I'll be discussing here is about atherosclerosis, the complications. Hello, Ginger Kitten. We'll go to aneurysms. We'll go and have a quick look at vasculitis and also a little bit about your myocardial infarction. Fine. If you have not downloaded the app, please download the app. Once you go to the home screen of the second year, you will have the FARRE PDF for you available for you. So I'm going to more or less cover on the same basis. So let's say there are 8 questions in CVS. I'll be trying to cover in the lectures like 4 or 5 questions. Little bit of less rest, little bit of put and effort. If you have any doubt in less of them, please ping me on Instagram or the Telegram group of PW. I'll be more than happy to help you guys, right? So with that note, let's go to atherosclerosis. So atherosclerosis can definitely be a long answer question because it has the right pitch of starting from definition. We have the risk factors, we have the pathogenesis, and also we have the complications and the clinical outcomes of atherosclerosis, right? So, like any other long answer question, the first part of any long answer question should be a definition of whatever they are asking about, right? So, can anyone tell me or define what does atherosclerosis mean in a couple of lines? Like I always used to say, need not be right from the textbook. Whatever you understand from atherosclerosis, maybe the term, maybe what you have read in your textbooks or you listen in your class. Can anyone tell me what does atherosclerosis means? So atherosclerosis, the term athero is your blood vessel, sclerosis, right? Sclerosis is nothing but your hardening or thickening of a blood vessel. That's all, right? So by definition, atherosclerosis is nothing but an event which results in lipid block is one of the pathogens of atherosclerosis, right? You are right in calling it lipid block, but I would say when I go for a definition, little bit of sophistication here and there, right? It's nothing but a thickening of blood vessels, okay, of blood vessels due to multiple risk factors, like you said. One of the thing might be lipid accumulation, everything, fine, due to proliferation of smooth muscles. That's very important because I'm talking what is causing the thickening of the blood vessel. One, whatever Meet said is right, I'll add on to that. Due to proliferation of smooth muscles, accumulation of the lipid, and also associated necrosis, okay? Accumulation of fat, lipid with necrotic event, right? So it's a chronic inflammatory process. In short, it's nothing but a chronic inflammatory process which is involving the blood vessel. So if I have to add a little bit more detail, if you want to capture the examiner's attention in the first line itself, thickening of the blood vessel due to proliferation of all of things in the tunica intima of the vessel, because that's very important. This is not a problem of the entire vessel. It's actually the problem of the tunica intima of the blood vessel. I'm sure you know about the 3 layers of blood vessel. Can anyone comment on the 3 layers of blood vessel? I'm sure you guys knows, right? It's tunica intima, tunica media, and tunica adventitia. In atherosclerosis, every problem, every pathogenesis happens in the tunica intima of the blood vessel. So if you want, you can underline this because that tells you that you exactly know what atherosclerosis means. It's not just thickening of a blood vessel. We know that it is a process involving the tunica intima of the blood vessel, right? So that's the first part. So once we are done with it, again, structure of the exam is very important. Fine. I Twitter Sangit. Hello, I hope your country is good and you are good as well. Fine. So the structure of an exam question is very important. One, I know the definition. Second, go with risk factors. Third, a point-wise pathogenesis, both the outcome of atherosclerosis and the complication of atherosclerosis, right? So when you go to risk factors, everyone must have known this risk factor. So I've just directly put the table. There's nothing much to discuss this. You must have been reading this from your NCRT days. The reversible and the modifiable and the non-modifiable risk factors in your heart attack or your atherosclerosis, right? So non-modifiable risk factors, genetic abnormalities is non-modifiable. If you want, put an example, familial hypercholesterolemias. That's definitely a genetic abnormality. It's non-modifiable, right? Family history, again, genetic abnormality in family history is kind of interlinked. Increased age, you cannot change for sure. Male gender, you cannot change for sure, right? So this is directly from the FARRE book. So FARRE is a very compact book, just help you to write the exam here. I'll add one more information here when we discuss, complete discussing both modifiable and non-modifiable, right? So when you look at modifiable risk factors, it's as simple as all the chronic disease, hyperlipidemia, hypertension, diabetes. So these are the three major things for me. We hope that cigarette smoking is modifiable. It's just in hope, right? So all these result inflammation of the blood vessel, right? So all these can be modified to some extent. If I'm having a very strict control of blood sugar, blood pressure, and your lipid, you will not have much of a problem. Like I said, I just want to add one more information here. The information here is there's a common thing for both modifiable and non-modifiable. Can anyone tell me what is the common for both modifiable and non-modifiable risk factor? Like this can be both modifiable as well as non-modifiable. What risk factor? You might have read that in biochemistry. Anyone? Have you heard about something called an hyperhomocystinemia? You might have definitely heard, right? So hyperhomocystinemia, again, this is something which can fetch you more marks. Hyperhomocystinemia can be non-modifiable if it's a genetic defect. There's an enzyme called a cystathionine beta synthase. If it's a genetic defect, it's non-modifiable. Same hyperhomocystinemia can also be due to vitamin deficiency, vitamin B12 deficiency, vitamin B6 deficiency. So these vitamin deficiencies also can cause hyperhomocystinemia, which is modifiable risk factor, right? Again, this is for an extra mark. That's all. So, but if you can finish this, that takes care of maybe 1 or 2 marks in a long answer question. We know the definition, 1 mark for it. Yes, definitely, right? So definitely we know about the risk factors which carries 2 more marks. The chunk of the mark is going to be for the pathogenesis. Okay, meet. When I say vasculitis, so I do accept that smoking is one of the important risk factor or the etiology for Burgess disease or thromboangiitis obliterans, right? So if it can damage the blood vessel endothelium of a very tiny blood vessel, right? Am I right in saying that it is possible to damage the endothelium of an iota also, smoking? It can, right? So smoking causes endothelial damage. If it happens in a medium-sized small vessels, it can cause your Burgess disease or thromboangiitis obliterans. Smoking can cause endothelial damage of a bigger vessel also. Provided I have other risk factors, it can result in atherosclerosis, right? Yes, for sure, I'll do it. If you want anything specific on video on FMG, I'll definitely do that as well, right? Okay. So we know about the risk factors here. So once risk factor is taken care of, like I said, it has to be pathogenesis, right? I told that atherosclerosis is simple chronic inflammation. In 2 classes before, we saw about inflammation. We also understood how a acute and a chronic inflammation works, right? We're going to say apply the same thing. Everything in systemic pathology is an extrapolation of general pathology. So the first thing, it's very, very important. 2 points which I look for when you start the pathogenesis of atherosclerosis. One, the starting point of atherosclerosis is always endothelial damage. This has to be present there. It's endothelial damage which starts the atherosclerosis, and atherosclerosis is nothing but a chronic inflammatory damage. In general, the entire thing is nothing but chronic inflammatory pathogenesis. It's just a chronic inflammation which happens in the blood vessel intima, because endothelium is nothing but the tunica intima here, right? So these 2 points, it's must for me to be in an exam. Because these are the 2 points I look for as an examiner. Okay, if these 2 are present, the first step is done. Maybe I'll put 1 mark for these 2 points alone. That's all. So then I have to explain how an endothelial damage and chronic inflammation will result in an atherosclerotic block. Let's go one by one. Everyone who's online, I want your active involvement here, fine? So this endothelial damage is my first step. Let's put stepwise. If you want to make it more appealing, you can write step 1, step 2, step 3. Please, whenever you write any steps, put vertically and preferably take a new page. Align it as per so that it comes in a fresh page. Because if you draw 3 steps in the first page and 3 steps in second page, might not look so pleasing. Fine. Okay. So step one here, for me, like I said, it is going to start with an endothelial injury. So these endothelial damage, it's actually, I'll just ask you one more different question. If an endothelium is damaged in any part of the body, what is my body's response? What do you think will be the body's response? My endothelium of some blood vessel is damaged, destroys. How will the blood vessel respond to it? Will it produce clot formation? Yes or no? It will definitely produce clot formation, right? It will. So here, endothelial damage alone is not enough for me. That's one point is very, very important is it's microvascular damage. The damage has to be very, very tiny because if it destroys, it will form a clot. If it forms a clot, atherosclerosis is not going to happen. It's tiny damage. There's tiny damage. That's what triggers everything here. Fine. So there's a tiny damage or microvascular damage. If you want, draw a diagram here. Put a blood vessel, draw an endothelium, maybe one endothelium alone, draw it a little bit irregular. Again, it's not a complete loss. If an endothelium is completely lost, and if the subendothelial collagen is exposed, one Willebrand factor comes inside, causes a clot formation. It's a microvascular damage and irregular damage, that's all. So once the endothelial damage happens, can anyone tell me the next step? Hi Himanshu, good evening. So after endothelial damage, what do you think will happen? The tiny damage. Here is where my risk factors come in. So I'm having a tiny damage to the endothelial membrane, the endothelial cell membrane, that's all. If the endothelial cell membrane is tinily damaged, and if the patient is having hyperlipidemia, is there a possibility that the lipid can enter the endothelium? It can, because it's a damaged endothelium, right? So the risk factor, if there's an increased LDL, here I don't want you to write as hyperlipidemia again. I want you to be very specific. LDL is one of the bad cholesterol, and one more important thing, lipoprotein A. Lipoprotein A is called a little rascal, right? It's definitely a very tiny molecule and it's definitely very, very bad. So LDL increase, HDL increase is not a problem for me. Increase in LDL, to be specific, increase in oxidized form of LDL and lipoprotein A. These are the risk factors which the patient already has. So in a tiny damaged endothelium with these risk factors, what happens is this fat enters the endothelial cell. In a normal blood circulation, if there's no damage, the fat cannot enter the endothelial cell, right? Now this fat enters the endothelial cell. Now here, I want you to correlate a little bit of immunology if you want to. If not, just we'll skip to the next step, right? So once the fat enters the endothelial cell, what happens is it is being captured by a receptor called as nod-like receptors. There's a mention about nod-like receptors in the immunology chapter of Robbins. This nod-like receptor is going to activate a complex called as inflammasome. Okay? So once it activates inflammasome releases interleukins. That's what happens, especially interleukin 1. So once an inflammasome is activated and interleukin 1 is also activated, am I right in saying that this interleukin can definitely further damage the endothelium? Yes or no? Can they? They definitely can damage endothelium, right? So here, this fat which enters is triggering a tiny inflammation, right? So once this happens, this will cause endothelial damage. It will cause further endothelial damage. And like someone said, once I have endothelial damage, like Meet said, I will have a regeneration for sure, right? This will definitely heal back. See, this is a normal cycle. This is not atherosclerosis. It's a normal cycle, that's all. But can I say in atherosclerosis, I'll just go up a little bit. This microvascular injury is repetitive or once a event? Do you think hypertension which causes injury will be only once in the lifetime or it will be repetitive? Repetitive, right? So this risk factor, oxidase LDL, lipoprotein A, once in an event or throughout life? Uncontrolled hyperlipidemia throughout life, right? So all these here is not a one-time event. If it's a one-time event, it would have ended with this endothelial damage, it heals automatically. But here, the biggest problem is all these are chronic risk factors. So when I have all these chronic risk factors, it will not let the endothelium heal. It will cause further damage. That damage here again, there'll be more entry of oxidized LDL. There'll be more interleukins, inflammasome activation, more damage starts to happen, right? So this is where it compounds because the risk factors are permanent. I'm not having a very well controlled risk factor. It's all permanent here, right? So once this happens, what is going to happen here is, let's draw a little bit bigger because we are going to predict that the amount of damage happening here is more than what we expect. There's more amount of endothelium only. It never comes to your tunica media. It always stays only in the endothelium. More endothelium damages. More endothelium gets destroyed by interleukin. Will it cause necrosis? Yes or no? It will definitely cause necrosis, right? So once it causes necrosis and there is lots of fat and I'm having a very chronic inflammation here. What is the cell of chronic inflammation? Good evening, Anjana. Can anyone say what is the cell of chronic inflammation? Because I'm having a chronic risk here. What is the cell of chronic inflammation? Cell of chronic inflammation is macrophage, right? It's not lymphocyte. Perfect. So here, first I'll have necrosis in the center. I'm drawing pink color for necrosis. Necrosis will be there for sure, right? And maybe yellow color just for us to identify its fat. This is chronic inflammation, like Mead said, I'm going to have macrophage entering here. We know about chronic inflammation. The role of macrophage is very, very simple. So once there's a necrosis, fat accumulation, I'll just name this as macrophage. The macrophage enters the area. Again, this macrophage comes from the blood monocytes. Monocytes become macrophage and they come here. So here, the macrophage's first role here is to try to remove the necrotic debris and also try to remove the fat. Will they remove or not? They'll definitely be able to remove, right? But once they remove, do you think the risk factors will stop or it will keep on persisting? It will keep on persisting, right? So it will try to remove, but again, more and more and more hyperlipidemia, more endothelial injury. It's a chronic problem. It's not a once in a event. It's a chronic problem. It's a repetitive problem, right? So it will try to remove that. Once it removes, again more injury comes, it will try to remove again, right? So once it removes, second thing is these macrophages turn to something called an activated macrophages. If you remember our second lecture on inflammation, what we had in the FARRE series, what is the function of activated macrophages? Can anyone comment? I'm sure you know the function. What is the function of activated macrophages? Activated macrophages do not phagocytose, they secrete. So these secrete TGF beta, these secrete PDGF, the growth factors, right? So these secrete growth factors, these growth factors are the one which attracts the smooth muscle from tunica media. Okay, it attracts the smooth muscle and then they make them produce collagen because TGF beta attracts fibroblasts also, right? They'll produce collagen as well, which means there is fibrosis, which obviously result in thickening. Every chronic inflammation, the hallmark is tissue destruction, healing by fibrosis. That's all, right? So this is going to be the end stage. So when this happens, how my vessel is going to change is, I'll have the same endothelium, the broken endothelium. I might have a little bit of necrosis, not too much. Definitely a bit of necrosis. Definitely I'll have a little bit of fat as well. Definitely you'll have the macrophages which are engulf the fat. These are called as the foam cells, right? Macrophage engulfing the fat, that will be there. Plus I'll have smooth muscle coming from the tunica media, right? Now in order to explain something in the form of an image, it's very, very important to make sure you draw the proper structures. Can anyone name what is the layer between the endothelium, that is tunica intima, and the tunica media? There's one layer. Can anyone name that? We have gone through this when we were discussed blood vessel chapter in detail. There's one layer between your endothelium and your tunica media. That's your internal elastic lamina, right? So that's very, very important. Try to draw it here. So you know for a fact that all the damage here happens in the endothelium. And if you want, I want you to write here also internal elastic lamina, right? See, because tunica media is where you'll have the smooth muscle, and draw smooth muscle here in the tunica media. every mesenchymal cell you're going to draw with an elongated nuclei, right? And also try to draw that this smooth muscle from the tunica media is the one which comes to my tunica intima, because intima does not have smooth muscle. Media has a little bit of smooth muscle, and all the smooth muscle comes here. Okay, I'll have smooth muscle. Obviously, you'll have collagen, fusing structures. You'll have collagen, smooth muscle, everything. So once I have, it's kind of forming a scar. Right? Scar is nothing but formed of smooth muscle, fibroblast, and collagen. Right. So I've formed a scar. Am I right in saying that beyond this, the endothelium will again form back? Because any scar formation, the top layer will definitely form back, right? So draw the top layer also. That's also very important. It will just, the necrosis will not be opened into the lumen. It will definitely have an endothelial covering for sure, right? So here, this is what is called as an atherosclerotic block. So once it's done, write two terms. Both the terms are important. So this results in neo-intima formation or an atherosclerotic block. It's block. Block means irregularity, right? It forms an atherosclerotic block. Fine. If you want to specify few things, you can here easily specify. In the center of this block, what do we have? What do you have in the center of the block? Can anyone tell? In the center of the block, we have, perfect, we have your lipid core, necrotic core, and maybe a little bit of your macrophages. The top one, can I call it a fibromuscular cap? Yes. So if I have to mention, you can say that the top one, I have a fibrous or a fibromuscular cap. Meat, I won't say it's covering the block. See the entire thickness here. Everything I'm going to call it a block. That's all. It's not just the fibrous cap. The fibrous cap along with the central necrotic core. Okay. I'll have the central necrotic core, the fibrous cap, the overlying endothelium. Everything constitutes your atherosclerotic block because it's a thickening, right? Block means irregularity. I cannot say only one layer is causing irregularity. Every layer will cause irregularity. Fine. I hope you understand. Fine. So this is what will cause atherosclerosis. Okay. Again, I'll go up just to quick revision. It's a stage-wise thing. Two things important: chronic inflammation of the tunica intima and starts with endothelial damage. A tiny microvascular injury lets the fat come in. The fat will be picked up by knot-like receptors. Inflammasome will act, interleukin will be produced. It causes further endothelial damage. If all the risk factors stops, it will heal for sure. But never happens, right? All the risk factors are chronic. Once it's chronic, the endothelial damage widens, necrosis happens, macrophage comes in, tries to remove everything, but again, the risk factors are chronic. So it keeps on damaging more and more. The macrophage becomes activated macrophage, secretes TGF beta, PDGF, and smooth muscle derived growth factors, and it will attract the smooth muscle from the tunica media, forms the fibrous cap. The smooth muscle actually confers one more property called as myofibroblast. It also has a fibroblast nature. That's why it produces collagen, which forms your atherosclerotic block. Right? So now I know how an atherosclerotic block happens. So three parts of the question we are done with. One, definition, risk factors, pathogenesis. Nothing in systemic pathology. See, this is systemic pathology question, right? So in general pathology, if you don't have a clinical correlation, I don't mind, because general pathology is more of a theoretical topic. But in hematology and in systemic pathology, if you don't consider patients, it's an incomplete answer. Clinical outcome should be part and parcel of whatever disease you're going to write. It's not just the pathogenesis. Clinical picture is definitely important. Even if not complete, at least a little bit of clinical information is required. Fine. So now let's look at the clinical outcome. So here, what has happened to the blood vessel is the blood vessel post atherosclerosis. What will happen to this blood vessel? The first one is obviously I have a simple normal blood vessel. Let's assume it's a normal blood vessel and with a beautiful lumen. After atherosclerotic, what happens is I'm going to have a blood vessel with a bulged intima. Maybe just put a thing here. The intima is getting bulged here, right? So that's an intimal problem. Okay, where did it go? Okay, so here I'll have an intimal thickening. Intima thickens. Can this grow further? It can grow further, right? Meet hemat, I will do it in last. We'll cover everything and I'll do hemat, right? We skipped the hemat because of scheduling problem. Fine. So once this goes, the block grows further. The block grows further. The block thickens. So at some point of time, this block can occlude the blood vessel. That is when I have a problem. If there is only atherosclerosis in the wall without occlusion of the blood supply to any particular organ, we don't have a problem at all, right? The plaque grows and it occludes, that's all, right? So here, it can happen in abdomen aorta. It can happen in myocardial vessels. It can happen in cranial vessels. These are the major concern. It can also happen in peripheral vessels. Okay, peripheral vascular disease also is possible. Popliteal it can happen, but my major concern is going to be heart and your cranial vessels, right? Perfect. Aditi is right. Critical stenosis is where I have a concern, right? So here, when the plaque grows, I have two possibilities or three possibilities, fine. One, the plaque can get stabilized and it can recanalize. I'll use an image from Robbins. That's a very, very beautiful image for you to understand what exactly happens after atherosclerosis, right? I'll just come and explain it again. This is an amazing image. You have a lumen, right? A beautiful lumen here. First stage is fatty streak. The reason why I didn't talk about fatty streak is the stages of atherosclerosis is actually not much mentioned in the recent books. But yes, a fatty streak comes. Then only it becomes pathologically thickened. You can look at the image. It's beautifully slowly become thickened. Then the plaque expands. When the plaque expands, again, there are three possibilities. One, it becomes a plaque with a very thin cap. The cap is a fibrotic cap, right? If you look at this image, the necrosis is more than the fibrotic cap. But if you look at this image, it's thick cap and there's very little necrosis. If you look at this image, it's a completely fibrotic cap, no necrosis at all, right? So there are three possibilities. I'm not saying that everything will become the same. There are three possibilities, fine. So Aditi said, I have something called critical stenosis. Critical stenosis not happens always. Critical stenosis can happen mostly in a fibrotic plaque or a fibrotic plaque with a little bit of thicker, a normal plaque with a little bit of a thicker cap. Only in these places, critical stenosis will happen, right? So we'll stop here and we'll go up and we'll try to understand what happens exactly, right? So you now exactly know what happens to every blood vessel when there's an atherosclerosis. There are three different variations. Either the plaque becomes bigger, fibrotic, cap and a very small necrotic core, a very big necrotic core and a very, very thin cap, right? So let's say if it's a very thin cap, a thin cap plus a huge necrotic core. Okay? Because like I said, our understanding is, our requirement is the clinical extrapolation, that's all. And we are going to consider your heart or the myocardial infarction to extrapolate what will be the possible clinical outcomes. So if the cap is very, very thin and the necrotic core is very, very big, right? Is there a possibility the cap can rupture? Am I right in saying that the cap can rupture or it will never rupture? Is there a possibility the cap can rupture? Cap can rupture, right? If the cap ruptures, what's the topmost layer of the atherosclerotic plaque? Above the fibrous cap, what did we have? Endothelium, right? So if the endothelium ruptures, how will my body react? Body always reacts the same thing. The first starting point was also that, right? So if the plaque ruptures, it will result in a blood clot, right? So if this thin cap, the plaque can rupture. If the plaque ruptures, it results in a superadded thrombus. But when it results in a superadded thrombus, this thrombus is the one which will occlude the blood vessel. You can write, if you are good in drawing, you can draw a blood vessel with a very thin cap and you can draw a superadded thrombus. This is the outcome or the pathogenesis seen in case of an unstable angina. Since I said we are looking in terms of heart, we have to just look at that. That's all. It's an unstable angina. So unstable angina is an angina of the chest pain which happens without any exertion, or even it can cause sudden cardiac death. Might not be angina alone. It can sometimes even cause, if it's a very big thrombus, completely occludes, it can cause sudden cardiac death as well. Without any etiology or risk factor, without any hyperventilation, without any exercise, without any emotional stress, it can result in this, right? So the next thing possibility for a thick cap, right? So when I have a thicker cap, here it's kind of more or less stable. It won't rupture. So this thick cap can alter, the lumen can alter based on a stimulus. If the person is going to exercise, heart rate increases, vasoconstriction happens, right? So whenever there's any strenuous exercise or any stressful stimuli, which could be emotional or it could be a physical exertion, any exertion, a physical exertion or an emotional exertion. So this causes little bit of vasoconstriction. So when vasoconstriction happens in a very stable block, I'm going to call this a stable block because it will not rupture. It's more or less stable, right? Let's assume that this is your stable block. Fine. There is 40 to 50% of the lumen still present, but unfortunately, there is vasoconstriction here. So what will happen is the block will be the same, but the lumen has become smaller, so it becomes critically stenosed. And here is where we end up in having stable angina, which is angina on exertion. If there's no exertion, the patient will not have angina. This is the same thing what we also use in case of your treadmill test. When you go to medicine, you will read something called treadmill test. In people with the risk factors, we ask them to run in a treadmill under controlled environment, introducing the physical test and see if there is any ECG change. That's what a treadmill test is, right? So there is one more possibility that this fibrous block itself can become more and more and more and more thicker and can critically occlude the entire blood vessel. I don't want a vasoconstriction. Critical stenosis is told when the cross it reduces to 70 to 75% of the cross sectional area. I call it critical stenosis, right? So this cap, a stable thick cap, can increase in the size and it can critically stenose. So critical stenosis is something when it includes 70 to 75% of the area of or the lumen of the blood vessel. It's critical stenosis. So when it results in critical stenosis, there's no possibility, even without a physical exertion, but even walking can result in angina. Fine. Means that's also possible. See, the one possibility which I have not put here is the thrombus can get recanalized. That is possible. The entire block can become very subtle, stable, possible. The thing what you're saying, it completely heals with epithelialization is possible only when there's a very long-term control of all the risk factors and a very strict control. If the risk factors still persist, there's a possibility it will never settle. Right? So if a person is having an 20 years, not a good control of diabetes, hypertension, but after 20 years, controls everything with drugs, with diet, with exercise, everything. The next 10 years, the risk factor will definitely reduce, right? It's all a dynamic thing. I cannot say when it will reduce because there are too many factors involved here, right? So these are the clinical outcomes of little bit of clinical outcomes of your atherosclerotic block. So it's not just this. We have talked only about the lumen here, right? We talked about lumen, if it occludes, if it doesn't occlude. So am I right in saying that when I'm having a scar tissue, is scar tissue as strong as a native tissue or it's weaker? What do you think? A scar tissue strong as a native tissue or it's weaker than the native tissue? It's any day weaker than the native tissue, right? So when I have a scar tissue, can I also say that it will destroy the entire blood vessel wall? It's possible, right? So this is with respect to the lumen. Without respect to lumen, so this scar or atherosclerosis definitely can weaken the vessel wall. If it weakens the vessel wall, that's my next thing. It can result in aneurysm. It can weaken the vessel wall. If it weakens the vessel wall, obviously atherosclerotics can induce aneurysm. That's one of the most common causes of aneurysm as well. Fine. Okay. Perfect. So we are going slowly to the next topic. If you are asked a question only on atherosclerosis, kindly stop with this. Maybe you can add one or two words regarding aneurysm, but not much. Stop with weakening of the blood vessel wall, causes aneurysm, and the complications. You have a definition, you have a risk factor, you have pathogenesis, you have clinical outcomes and complications, right? That should be more than enough, fine? Now let's go to aneurysm. What do you mean by aneurysm? First, before writing aneurysm, can be collectively kind of put out the points, whatever everyone here online knows, and try to form a question. So because the most important thing in an exam is the first 1 or 2 minutes you think before writing the exam, so that you can properly structure the exam. What all you think is important to structure a 5 mark question on aneurysm? Anything. Meet Aditi, Suresh, if Anjana, if anyone, if you're online. What all the points comes to your mind? First, do I need a definition? Obviously, right? I would need a definition. That's obviously a starting point for any question, right? So first is going to be definition. So after definition, what I want is there are different types of aneurysm. We classify them as your pseudo aneurysm, true aneurysm, vascular, fusiform, tortuous, right? That's one, right? Okay. So I have a classification, risk factor, perfect. So risk factor will almost always be linked with the pathogenesis. There are two major risk factors for aneurysm. One is atherosclerotic induced, second is inflammatory induced, third is infection induced. Right? So the major aneurysm, what I am concerned about is in the aorta. If I have aneurysm in this part of the body, it's not important for me. As an aortic aneurysm, it can rupture and I can lose the patient. Perfect. Tutu Vasava said sites. That also is important. Major thing, like I said, it's abdomen aortic aneurysm and a thoracic aortic aneurysm, because the question will generally be on aortic aneurysm rather than general aneurysm. When I have other areas like traumatic aneurysm also can be there. Just one word, that's enough. But abdomen aortic aneurysm is where we are going to concentrate much more on. And obviously complication. What do you think will be the worst complication of an abdomen aortic aneurysm? It's abdomen aortic aneurysm. It's a huge aneurysm and the aorta is like 6-7 centimeter dilated. What do you think will happen? It can easily rupture, right? The rupture is definitely one of the cause of abdomen aortic aneurysm, and it ruptures. Definitely, there's a possibility that we can lose the patient's life as well, right? So it's just structure. 1 minute, you and we both discussed how to write it. So once you have structured that, even in exam hall, it's okay to spend 1 minute, 1 or 2 minutes. So once you spend 1 or 2 minutes, you know exactly what to write, right? Meat, yes, it can cause atherosclerotic plaque itself can cause, it can rupture, and it causes something called a fatty emboli. That is possible. It's one of the commonest emboli which can happen in the renal artery, because abdomen aorta is the commonest site for aortic aneurysm or atherosclerosis, and the branch is renal artery where it can easily cause an atheroemboli. That is possible, right? Okay, let's come back to aneurysm. You guys said definition is the first thing. So for definition, aneurysm is a permanent abnormal dilatation of the vessel wall. If it's a transient dilatation, I call it vasodilatation. I don't call it aneurysm. Due to congenital or acquired weakening of the the vessel wall, we'll look at the causes very soon, right? So aneurysm by definition, it's a permanent abnormal dilatation of the vessel wall. You are not mentioned one side or two side because there are different types of dilatation, okay, of vessel wall, which is due to a congenital or an acquired damage to the vessel wall. It can be damage to one or more layers of the vessel wall, but you can just write damage to the vessel wall layers. Okay. Fine. So by this definition, you are introducing that there is a possibility that congenital also aneurysm can happen. Can anyone give me one example of congenital aneurysms or developmental disorders? One example. I'm sure you know that. I'll give you a clue. This happens in the brain. Base of brain, to be very specific. Anyone? I'm sure you know this, right? You must have heard about, everyone here must have heard about perianeurysm, right? So perianeurysm is definitely one of the types of congenital form of aneurysm which can definitely happen here, right? Perfect. Okay. So we have got a definition here. Now we have to kind of, like whatever we structure, we'll have to come to the classification. So the classification is actually of two different types. I can classify it based on the what is there in the wall of the aneurysm, right? Marfan's is also a syndrome. Yes, Marfan's can also be put as congenital, but Marfan is destruction of the vessel wall due to fibrillary mutation, and both of them can be classified as congenital aneurysms. Fine. Okay, let's come back to the classification. One, It's an anatomical classification. So most of the anatomical classification over the period of time, they convert into radiological classification, right? Because if I know the anatomy, if I take a scan of it, the anatomy is what converts to radiology, right? So anatomical radiological classification. So we divide aneurysms based on the appearance. We call something as true your fusiform aneurysm. We call something as your fusiform aneurysm is there, and we call something as an saccular aneurysm. Okay? There's one more type of aneurysm which is not present written in your Robbins. It's an older classification. If you want extra marks, you can write that. There's a type called as tortuous aneurysm. Okay? I'll tell you what does tortuous mean. Fusiform and saccular is explanatory, right? So it's fusiform. If there's a blood vessel, it's going to look on the both the direction. If you remember first year, smooth muscle or muscle has a fusiform belly. Both the sides swelling is called as fusiform. Saccule. It's a sac. It's either one. So one side I call it a saccule. When I have something called as tortuous, right? So tortuous is an easier way for me to explain tortuosity. Have anyone seen a patient with your varicose veins? Have you seen varicose veins? Anyone have you seen varicose veins patients? If you've seen varicose veins patients, you can easily relate what do we mean by tortuosity. It's a continuous thing. It makes the entire vessel wall look bit different. That's tortuosity, fine? Okay. So this is based on anatomical or radiological fact. Like I said, etiological fact also I can classify. Etiology wise, I can put congenital. You guys told both the important congenital aneurysm. One, I can add berry aneurysm. If you want add, it happens in your circle of Willis, just an add-on thing. Then Marfan syndrome can definitely cause aortic aneurysm, which everyone knows. It's also a congenital thing. It's a congenital disorder. Fine. Then I have acquired. Then acquired, the major cause of acquired aneurysms is atherosclerosis. Even in abdomen, the major causes atherosclerotic induced abdomen aortic aneurysm. Almost in every part of the body, one of the important causes atherosclerosis, right? Then I have something called an inflammatory. There's something new which has popped up. So when I say inflammatory aortic aneurysm, fine? Sure, we will do it. Okay. So in inflammatory aortic aneurysm, what we'll have is we have something called as an IgG4 related disorders. So IgG4 related disorders causes inflammation in multiple parts of the body. It can cause inflammation to the aorta also, which can destroy that, right? Third part here, I can have infective. So infective aortic aneurysm, one of the biggest and the most important or significant infection is syphilis. Though we don't encounter much case of syphilis, that is definitely one of the important thing. The last but not the least, again is acquired, is traumatic. Traumatic aortic aneurysm is especially common in peripheral arteries, especially common in popliteal arteries. Or you can just write peripheral artery. The commonest cause of traumatic popliteal artery aneurysm is trauma. A person hits, weakens the vessel wall, obviously can result in an aneurysm on a later date, right? So one is based on the anatomical radiological. Second classification is based on the etiological. I have a congenital and I have few causes of acquired, right? The third cause is based on the vessel wall, right? So if you remember diverticula, you must have heard about diverticula. We call them a true diverticula and we call it pseudo diverticula, right? So this is an image from Robbins. Tell me which of these two marked. I want everyone to comment here. Which you think is an saccular aneurysm, one or two? Which is saccular aneurysm, one or two? Definitely one is your saccular aneurysm, right? It's saccule. Here, it's both the sides is expanded, so it's a fusiform aneurysm. That's an anatomical classification, right? Perfect. So this here, other type of classification, we call something as a true aneurysm, and we call something as a pseudo or a false aneurysm. That's my third classification, right? Okay. So when do I call it as true aneurysm? Be it true diverticula or true aneurysm. The only classification is based on what I see in the wall of the aneurysm, right? So you can just write this, put a line here and write, if the wall of the aneurysm has all three layers of the blood vessel, which is tunica media, intima, and adventitia. I call it a true aneurysm. Wherever location, it doesn't matter. Be it in the head or in the foot, doesn't matter. If the wall of the aneurysmal sac has tunica intima, media, adventitia, I call it a true aortic aneurysm. On the other hand, if you look at the false or the pseudo, I'll just zoom this a little bit so you can easily know the difference. So if you see here, this is the aneurysmal wall, right? Aneurysm is nothing but a bulge. It's actually not an aneurysm. What's happening here is there's a trauma here. I hope you can see that. This is the end of the vessel. This is the end of the vessel, right? There's a trauma here. Because of the trauma, the blood goes there and the extravascular connective tissue stop the blood. It's slowly leaking. So this is called as a pseudoaneurysm. It's actually not an aneurysm. Pseudoaneurysm is where the wall will not have all three layers. It's actually an perivascular hematoma. It looks like an aneurysm for a patient or for a doctor when they see it's a bulge in the blood vessel. Most important examples for pseudoaneurysm is post MI aneurysm. Post MI, I can have this damage. Meet, it's not adventitia being maintained, it's a perivascular connective tissue. There's a slight difference between adventitia and perivascular connective tissue, right? I'll zoom the image only. You can see them. Can you see the three layers? Intima, media, adventitia, right? So what stops the blood is a layer next to the adventitia, the fascia, the perivascular connective tissue, fine? So post-MA aneurysm is the first aneurysm. The second thing is aneurysm at the anastomotic site. This you can easily relate. See, what is an anastomosis? You unite two blood vessels, we call it an anastomosis, right? So I have a surgery and I have to suture two blood vessels. I put a needle inside and prick the blood vessel. I am damaging all the three layers for sure. There's a thread going there and we tie it. Is there a possibility close to the thread there's a gap and the blood can slowly leak? It can, right? That gets collected in the tissue and it causes an aneurysm, right? The anastomotic site and post-MA aneurysm are examples for pseudoaneurysm, right? So we know the different types of aneurysm and the classification, right? Now let's come to the pathogenesis a little bit. We'll look at abdomen aortic aneurysm first, and obviously then we'll look at your syphilitic aneurysm, because that's also an important cause of an aneurysm, right? So abdomen aortic aneurysm, I'm going to try to include all the pathogenesis in a simple short form, right? Abdomen aortic aneurysm is undoubtedly the commonest cause of aneurysm. Atherosclerosis is a major cause of abdomen aortic aneurysm also, fine? So abdomen aortic aneurysm, anything greater than 3 centimeter, the lumen, you call it an abdomen aortic aneurysm. If it's greater than 5.5 centimeter in diameter, there's a chance of a rupture for sure, fine? Okay. So when you look at abdomen aortic aneurysm, the pathogenesis, there are multiple components which comes here. The first and the important thing is atherosclerosis. So atherosclerosis, it definitely will cause scar tissue, and the scar will weaken the vessel wall. That's self-explanatory, right? Second and the most important thing, like I said, the new one which is getting added is inflammation induced. There's something called an inflammatory aortitis. So this inflammatory aortitis is very common in a disease called as an IgG4 mediated diseases. IgG4 mediated diseases will have lots and lots of plasma cells because IgG4, and will have your fibrosis. It has something called an very unique type of fibrosis, and have lots of dense lymphoplasmacytic infiltrate and obliterative end arteritis, right? So this again will, since it's fibrotic, this will result in fibrosis because of the inflammation induced fibrosis. That will definitely weakens the wall. Okay. The third thing I'm going to introduce Marfan's also. Though Marfan, it will cause more of thoracic aortic aneurysm, abdomen aortic aneurysm also possible in Marfan's, fine? So Marfan syndrome, what happens in Marfan syndrome is there's a loss of fibrillin. Fibrillin is the one gene which is getting mutated in Marfan syndrome, right? Because of the loss of fibrillin, there's going to be destruction of elastin, which destroys elastic fibers. Can I say aorta is an elastic artery? It is, right? So this destruction of elastic fibers obviously will weaken the vessel wall. So either because of atherosclerosis, or because of inflammation, or because of Marfan's, at the end of the day, I'm going to have a weaker wall of the aorta. So all this contributes to your abdomen aortic aneurysm. It's more common in an elderly person, 50 plus years, because it needs good amount of time for any pathogenesis to go and slowly destroy it. Smokers, it's a little bit more common because again, smoking will contribute to all this. Smoking itself can cause more damage, right? So we can see wall, and the age group is generally fifth or sixth decade. Smoking aggravates it. Smoking is also a risk factor because smoking can cause damage and is definitely a risk factor. Okay? Smoking is definitely a risk factor. In inflammation, you can even add giant cell arteritis or your Takayasu arteritis, which is a large visual vasculitis, which also can cause that, right? So here, and the complications. So first, how do you identify them? Clinical symptom, they will present as an abdomen mass. Abdomen mass, which are pulsatile. That's very, very important. Pulsatile abdomen mass is the first finding of an aneurysm, right? Ananda Kishore, I'll do it. I don't have it now because the cardiac genetic anomalies, the ASD, VSD, actually they are not hardcore pathology things. You will read lots of them when you go to pediatrics, right? Robbins covers lots of them in cardiac pathology, where the real role of pathology is very, very minuscule, but definitely I'll cover for sure. Fine. Okay. Meet, you're right in saying that sclerosis is thickening. A chalk is also very, very thick. Doesn't mean that it's strong, right? Whenever this fibrosis happening, the scar tissue can never be as good as my native tissue. It's a scar tissue. Scar will always be weaker than the native tissue. Though it is thick, doesn't mean it's always stronger. The tensile strength is definitely less. Fine. Okay. But you find them as an abdomen aortic mass. There are few other possibilities of few other symptomatology, right? So it's an abdomen aortic aneurysm, right? It's a huge aorta. Can the aorta compress an adjacent organ? They can. So you can have impingement features. It can impinge on the adjacent structures. Especially impingement features can erode vertebrae. So the patient can present with an vertebral pain or a low back pain. That also could be a finding, fine. Or there is a possibility that it's an aneurysm. Can aneurysm predispose to thrombus formation? It can. It's a sac, right? So aneurysm will definitely predispose to thrombus formation. Thrombus might be present in the aneurysmal sac, which might break off and become an embolus. So the patient can present an embolic episode, can present a stroke. Then I find out, okay, there's an abdomen aortic aneurysm, which is the cause of that. Can present with an peripheral vascular embolus, anything of that sort, right? It can also present with an acute emergency of rupture. Rupture is an acute emergency. Even with treatment, mortality rate is very, very high because the aorta ruptures. It's very difficult to control. Most of the patients die even before coming to the hospital. Sudden hypovolemic shock, the patient goes for a toss, fine. Okay. So these are the clinical possibilities or presentations of an abdomen aortic aneurysm, fine. So we know about abdomen aortic aneurysm. And obviously the treatment, I just give a brief line about the treatment, but I'll leave it to the surgeon. When you come to surgery, they'll give you lots more important thing about the treatment, right? So treatment of abdomen aortic aneurysm is you have something called a graft. You put a graft around the aorta, so it makes it's like an support. That's all, right? So the graft or a stent, fine. So generally the graft done is Dacron graft. Dacron graft to cover the aorta and provides tensile strength to the aorta. It's expandable. So the wall is weak. So I provide an artificial wall. That's all. Fine. Good evening, Rajshri. I'll just tell you, Meet. I'll tell you the difference between an dissection and an aneurysm. Fine. Okay. So that's about abdomen aortic aneurysm. Just a word on syphilitic aneurysm because syphilis also can cause aneurysm. Syphilis is very unique in causing aneurysm. We'll just go and have a look at it. Though the instance is very rare, but syphilitic aneurysm is one of the commonest or very likable question in the Viva. Most of the pathologists want to talk about syphilitic aneurysm. Though it's long gone, we never forget history, right? Okay, perfect. Rebacking. The syphilitic aneurysm involves the ascending aorta. It does not involve the abdomen aorta. Almost every case of syphilitic aneurysm will be in the ascending aorta only. The pathogenesis here is very simple. So the pathogenesis of syphilitic aneurysm is syphilis causes obliterative end arteritis. It obliterates end arteries. In aorta, I don't have an end artery. So in aorta, it's going to obliterate your vasa vasorum. What does vasa vasorum mean? Can anyone tell me what is vasa vasorum? In aorta, vasa vasorum is the end artery. It obliterates vasa vasorum. So what I mean by vasa vasorum is it's a blood vessel in the tunica adventitia of every blood vessel which supplies the blood vessel. I am sure everyone knows what vasa vasorum is, right? So once vasa vasorum is obliterated, it destroys the outer third of aorta, because vasa vasorum supplies the outer third of any blood vessel, right? So once it destroys the outer third of aorta, it will result in necrosis. Necrosis will undoubtedly be followed by healing, and every healing is by fibrosis. Okay, it will definitely undergo fibrosis. So the outer half is getting fibrosed. The inner half is normal because the inner half gets its blood supply from your lumen. Fine. Is everyone having lagging? Jarshi, can you just refresh once? It looks decent for me here. Fine. So what happens here is, if this is my abdomen aorta, and for understanding the lumen of the abdomen aorta, I'll have fibrosis in the outer half. The outer half alone undergoes fibrosis. The inner half is absolutely normal, right? So if the inner half is absolutely normal and the outer half undergoes fibrosis, this will weaken the vessel wall. Okay? So once it weakens the vessel wall, automatically it will cause aneurysm. That's no rocket science saying that it will definitely cause aneurysm because there's a fibrosis anyway, fine. So again, the same necrosis and the outer half fibrosis leads to one more finding which meets at the tree barking. So this necrosis and fibrosis in the outer half, it pulls the intima, because every fibrotic scar will pull, right? Once it pulls the intima, it causes the intima to be very, very irregular. This pull on the intima gives an appearance called as a tree bark appearance, right? I don't have the image. I'll share the image to you in Instagram. Okay, it's tree bark appearance, which is a classical appearance seen in case of a syphilitic aortic aneurysm, right? So this is about syphilitic aortic aneurysm. So we know a little bit about aortic aneurysm. Structuring a question is very, very important in a university exam. In university exam, it's all about the presentation. You have a definition, you have etiological classification, three types of etiology. You explain abdomen aortic aneurysm, you explain syphilitic aneurysm. See here, it's going to be just one, maybe 2 pages, more than enough. 1.5 pages more than enough for you for a 5-mark question. Don't keep on writing for 10-15 pages, not required. If you can give me all the information required for me in 1.5 page, I'll be more than happy as an examiner because I need not read through everything. 1.5 page, everything is there. Click, done. That's all. 4 on 5 or 3.5 on 5. Fine. I don't know if they'll give you 5 on 5, but they'll definitely help you to sail through the boat. Fine. Okay. Meet your question of what is the difference between aneurysm and a dissection, right? I'll use the same image for us to explain what is the difference between aneurysm and a dissection. Where is it? Yeah. Let's take this. Sorry, a pseudoaneurysm and a dissection, right? So if you look at this image, this is what a pseudoaneurysm is, where the blood escapes and the perivascular connective tissue is going to stop the blood. It's an hematoma, right? So what happens in dissection is the blood goes exactly in the media. If the blood goes in the medial space, I'll use a black color so it's much evident, right? The blood goes from here, it tears the intima and it goes to the media. This is what I'm going to call it a dissection. Dissection is to separate. That's what the actual meaning of dissection is. It separates the tunica media and travels between the tunica media. Here, in pseudoaneurysm, it destroys everything and goes outside the vessel, right? I hope you know the difference. One is between the media, one is outside the blood vessel, and the perivascular tissue stops that, right? That's the difference between an aortic dissection and obviously a pseudoaneurysm of an aorta. Fine. Okay. Let's go to the next part. Next part of today's section about vasculitis classification. Okay. I'm going to classify vasculitis and we'll talk about one vasculitis. The reason why I'm going to restrict myself to one vasculitis is if you know one vasculitis template, you can apply it for almost every vasculitis. The same template, different etiology. Because vasculitis is a very, very easy topic. It's an inflammation of the blood vessel, right? You know inflammation chapter? You know, right? I medic. If you know the inflammation chapter, you definitely can write any vasculitis because it's either acute inflammation, chronic inflammation, or an allergic response. You know all of them. Apply that to yourself. That's more than enough, right? So classification of vasculitis. Again, if it's a 5 mark question, just asking on classify vasculitis, right? You will have to classify a little bit more than what you already know. Because generally we classify vasculitis as what? How do you classify vasculitis? You guys know that. How do we classify vasculitis? We generally classify vasculitis into small, medium, and large, right? Based on the site of the vessel involvement, small, medium, and large. If it is a 5 mark asking only on the classification, do a two-tier classification. One, small, medium, and large. Second, infectious, non-infectious. In non-infectious, again, multiple subtypes of it. Because that will take care of a little bit of an extra thing, that's all. Sure, mate, I'll do that. So, a vasculitis classification. So, generally, the classification of vasculitis is based on the anatomical classification. Most of the textbooks follow them. A large vessel vasculitis, a medium vessel vasculitis, and a small vessel vasculitis. That's how generally all the classification goes, right? Though you read like this, I'm telling it now itself because when you go to medicine or pediatrics, you might have a confusion. If I call something as giant cell arteritis, which is a large vessel vasculitis, but in real life, it can involve medium vessels also. But when I read, we read as large vessel because 85% of them is large vessel. 5-10% of them can involve medium. So that is true for almost every vasculitis. These extra 5-10 percentage is more important when you become a PG. As an undergraduate, if you know 85% of a topic, that's more than enough. You have DM, you have MD, you have DM, you have fellowships, you have multiple places to fill in the extra 5-10%, right? So don't leave the 90% for the 5-10%, which is an extra push, right? The large vessel vasculitis, like you have giant cell arteritis or your temporal arteritis, and you have your Takayasu arteritis, right? So those are the two large vessel vasculitis. Medium vessel, everyone should know this. And one more Japanese name. Who is that? Kawasaki. And as well as Kawasaki. Give me a second. Okay, you have Pan and Kawasaki. In small vessel vasculitis, everything, any vasculitis you know, comes under small vessel vasculitis. You can have vaginous. You can have microscopic polyangiitis. You have something called Shock-Strauss syndrome. Okay. You have Buerger's disease. Meet was talking about Buerger's disease sometime before, or your thromboangiitis obliterans, right? Buerger's disease. There is a point of intermediate vasculitis, fine? Yeah, Buerger's too, right? Intermediate vasculitis. Generally, it's not there in Robbins. If you don't want to write that, don't write that. But intermediate vasculitis, it's between a medium and small vessel. Behçet's disease. It's a classical case of an intermediate vasculitis. If you want, add on to it, write it. I would say don't write because it's not something is very common. So if the teacher doesn't know or if the examiner is not aware of that, they might call it wrong. So this is simple. Stick with that. Maybe in a Viva answer if they ask if there is anything called an intermediate vasculitis. I do have an intermediate vasculitis because one school of thought neglects this idea of intermediate vasculitis, but one school of thought accepts that. So that's why I'm a bit hesitant to ask you to write an exam. But if you want in a Viva, tell Behçet's disease is an intermediate type of vasculitis, right? So this is an anatomical classification. So like I said, if it's only classification, I do want to know about the etiological classification as well. Etiology also is important for us, right? So in etiological, infectious and non-infectious, those are the major two things. Do you know any vasculitis which can be due to infection? Anything? Simple streptococcal can cause vasculitis, right? Any infection can cause it. So I can broadly classify into infectious Traumatic. When I say traumatic, it's not always mechanical trauma. Mechanical trauma is also there. Irradiation, chemical toxin, they also can cause vasculitis, right? So under trauma, it can be mechanical, it can be chemical trauma, it can be radiation induced trauma. Radiation will definitely injure blood vessel, it will cause vasculitis. Then comes your non-infectious vasculitis. Non-infectious is nothing but your immune mediated. So under non-infectious, again I have subcategories. Since I'm talking about the classification, little bit in depth, right, in detail, right? PSGN, yes, it's an infectious cause of vasculitis, right? I wouldn't put it as infection directly. It's an infection-related immunological pathogenesis, right? Okay. When it comes to non-infectious vasculitis, there are multiple subtypes. There are actually 4 specific subtypes, if I have to say. SLE is a vasculitis, for sure. SLE is immune complex deposition. SLE is a classical type of vasculitis where the main problem is circulating immune complex or an immune complex deposition. If you want, give an example, SLE. Everything in SLE is due to vasculitis only. Vasculitis is the one which causes complication in SLE, right? Okay, that's one. Second, can anyone tell me what is the etiology of Kawasaki disease? A classical etiology of Kawasaki disease. You know about Kawasaki disease. I wanted to know what is the etiology of Kawasaki disease. What causes Kawasaki? Kawasaki is a vasculitis seen in children. Everything fine. It causes myocardial rupture, aneurysm, everything is fine. Kawasaki is not due to infection, right? Kawasaki is an inflammatory thing, non-infectious. So Kawasaki, actually what we have is, we have anti-endothelial antibodies. Okay? So you can have an antibody to endothelium, which can cause a vasculitis. The best example for it is Kawasaki disease. Okay? Where you have an, actually to be specific, IgA autoantibody to the endothelium. That's what causes Kawasaki disease, fine? That's one. Next, again one of the non-infectious cause. The etiology for vaginous fructose and microscopic polyangiitis. We have one unique antibody. What is that antibody called as? We have 2 subtypes, PR3 and everything. PR3, MPO, CNP, and mediated, right? I'll answer your question, meet. Third thing for in non-infectious causes, ANCA mediated vasculitis. The ANCA mediated, there are multiple vasculitis. Like I said, vaginous is ANCA mediated, microscopic polyangiitis is ANCA mediated, Struxos syndrome is ANCA mediated, ulcerative colitis induced vasculitis is ANCA mediated, right? Perfect. Last but not the least is due to autoreactive T lymphocytes. Okay? If T cells are involved in a pathogenesis, is it an acute problem or a chronic problem? What do you think will happen when T cells are involved? Acute or chronic? It will definitely cause a chronic problem, right? It will involve T cells, it will involve macrophages. Whenever macrophage and T cells involve, it produces granuloma. This is the pathogens of your giant cell arteritis and your Aakyasu arteritis. It's an autoreactive T cell which kind of destroys everything, fine? So we have divided non-infectious cause into 4 groups. Aakyasu Kawasaki, and antibodies to endothelium is your Takayasu and GCT, and antibodies to endothelium is Kawasaki, ANCA mediated, and your immune complex SLE. Fine. We meet following an infection and due to an infection are 2 different things. When you talk about PSGN, I will not say it's due to streptococci. It's the immunity of the streptococci destroying that. Fine. Maybe PSGN I can put it to some extent because it's planted antigen. Rheumatic heart disease, I won't say streptococci destroy the heart. It's the molecular mimicry which destroy the heart, right? So there's a slight difference between calling it an infectious cause versus an immunological cause. If immunity is the one which destroys the organ, I put them under immunological bracket. If the bacteria goes, sits there, destroys, I call it infective. That's the only difference, right? I hope you understand that, right? Okay. So we know the classification. Like I said, I'll just give you a template of one vasculitis. Any vasculitis, first thing I want you to write is what type of vasculitis it is, large, medium, or small. That is required. Okay. Meet what is the treatment of Kawasaki? It's a large vessel vasculitis. Treatment of Kawasaki is immunoglobulin, right? IV immunoglobulin. And this is your homework. If possible, when you have time, read why we give IV immunoglobulin in case of Kawasaki. Fine. Okay. Fine. So it's a large vessel vasculitis. Second thing, asking for rheumatic fever. See, that's why. See, in rheumatic heart disease, why I am giving an antibiotic is, so if I'm having a streptococcus sore throat, my body, when it produces immunity, it will kill streptococcus. At the same time, it will kill heart. That's molecular mimicry, right? So now let's say that I'm having streptococcus sore throat. Before my body can give an immune response or produce an immune response, I give an antibiotic and kill the streptococci. Will I stop molecular mimicry? I will, right? So the reason of me giving prophylactic antibiotic or treatment antibiotic in case of streptococcus is I am not letting my immunity start. If my immunity protects, there's a side effect for me. So I intervene, give an antibiotic and make sure immunity doesn't do any harm. Fine. This is a large vasculitis. Then go for pathogenesis. So if you have giant cell arteritis alone as a long 5-mark question, explain the pathogenesis. If it's a component of a general question of vasculitis, just write what is the pathogenesis. Enough. The pathogenesis is chronic inflammation due to autoreactive T cells. This is enough. It's self-explanatory. If it's a part of another question, fine. If it's a 5-mark question per se, a little bit explain. What do I mean by this is, let's query some unknown antigen. We still don't know what antigens triggers this. It's an unknown antigen against which an autoreactive T cells is going to have an immune response. So whenever T cells bind to any unknown antigen, which will be presented by antigen presenting cells. That's how your antigen presenting cell will be the person who presents the unknown antigen to my T cell, and it creates a response and it produces an Th1 response. Whenever Th1 response is produced, the next step is it increases macrophage. Same thing what we thought, what we saw or what we read in case of your chronic inflammation and granuloma formation. Macrophage, to be specific, activated macrophages. That's nothing but your epithelioid cell. So all this epithelioid cell and your T cell together forms a granuloma plus giant cell. It's the same template for same thing for your Tachyas arteritis, same thing for your giant cell arteritis, right? Like I said, if it's only a part of a question, write this enough. If it's a bit explanatory, write this. Explain it a little bit. And obviously followed by whatever Aditi said. Tissue destruction heals by fibrosis for sure. That's end stage for any chronic inflammation, right? So it's going to end with tissue destruction healing by fibrosis. Now, then let's come to symptom. So it's a large vessel vasculitis. The other name given for giant cell arteritis is temporal arteritis, because everything was studied on the temporal artery, the superficial temporal artery, right? So the commonest symptom, or when the superficial temporal artery is involved, because symptom is based on the vessel involvement, and every vessel involvement here is due to fibrosis. At the end of the day, this will cause fibrosis of the vessel wall. If it causes fibrosis of the vessel wall, what do you think will happen to the lumen? Will it be smaller or bigger? The lumen will become smaller, right? This reduces lumen. This reduction in the lumen is the main problem in the pathogenesis. A superficial temporal artery, which will cause headache. Ischemia here. Reduce blood supply to this area, headache, that's all. Fine. Next, the same can go to maxillary artery. If it goes to maxillary artery, obviously it will cause jaw claudication. Pain on the movement of the jaw, right? It will cause jaw claudication. Same reason. Maxillary artery lumen will become smaller. When the maxillary artery lumen becomes smaller, the muscles of mastication will not get blood supply. it becomes weak on movement or painful on movement, right? Then if it goes to ophthalmic artery, that's a big concern for me, right? Ophthalmic artery, when it goes, it might cause blindness. Because the same reason ophthalmic artery blood supply becomes low, retina gets a less blood supply, it will cause a blindness, right? So these are few symptomatology. Any inflammation will have very non-specific symptom. Whatever I have talked here are specific symptoms. If you want, you can write the non-specific symptoms. Non-specific symptoms of any inflammation: fever, myalgia. That will be there for any inflammation, right? Even if you have a sore throat, fever might happen, myalgia, tiredness might definitely happen, right? But these are more specific and these are non-specific inflammation, right? So I know the pathogenesis, we know a little bit about the etiology, we know the symptomatology. Now my goal is diagnosis. In diagnosis, again, investigation can be both non-specific and specific. The investigation here, non-specific is like elevated ESR, inflammation, elevated CRP, acute phase reactants, it will be elevated. Again, a non-specific investigation, that's all. If I want a biopsy, and if a biopsy is done, what I'll be seeing is chronic inflammation. Like the name says, I'll see giant cells, I'll see granuloma, and there's a very, very classical finding. Tissue destruction is the hallmark. So for me to prove tissue destruction happens in the vessel wall, I have to destroy the most strongest layer of the vessel wall, which is internal elastic lamina, right? So here what happens is there'll be destruction of internal elastic lamina. This is important. Write them as pathognomonic. Pathognomonic, it's a classical finding seen in case of a temporal arteritis, fine. So once I know the diagnosis, I treat. Treatment is steroids, immunosuppression. Add one more point. Again, this is for an extra mark. The thing with temporal arteritis is, I have a very difficult complication of blindness, right? That's one of the complications of temporal arteritis. So do you wait for the biopsy report to come and then you treat, or you treat whenever you are suspecting temporal arteritis? What is the best way? Steroids. Obviously, treatment should start on suspicion. When you suspect temporal arteritis, start the treatment. Don't wait for it. Don't wait for anything. Do the biopsy, do the investigation. If it turns out to be temporal arteritis, well and good. That's not, taper steroids and stop it. That's what is about temporal arteritis, right? That's one of the arteritis. I just want to cover one more thing. This might come at least in a 2-mark question, or definitely can come in the Viva. We generally don't talk about Raynaud's phenomenon because Raynaud's is something, if you have gone through Robbins, you know for a fact that Raynaud's has no specific etiology. Either it's primary, it's idiopathic, or secondary thing which can cause Raynaud's, right? Has any one of you experienced Raynaud's phenomenon? You might have definitely known about Raynaud's phenomenon, right? Raynaud's phenomenon is actually not a vasculitis. It's more of a vasculospasm. It's kind of a misnomer for me to call Raynaud's, it's a vasculitis, right? Raynaud's is actually, it's not a true vasculitis. It's definitely not a true vasculitis. It's a functional vasospasm. It's just a functional vasospasm. It's just a vasospasm, that's all. It primarily involves the small arteries and arterioles located in the extremities, right? Which involves arteries, arterioles, especially in extremities. When I say extremities, it's not just your fingers and toes. Yes, fingers and toes can happen for sure, but it can also happen in your nose tips, earlobes also, right? It won't cause a problem because when I'm going to take superficial temporal artery, it's not a problem. But when I take like a temporal artery, yes, it is a problem. In the era of vascular surgery, where I can unite and anastomose things, this is not major concern. Again, doing a proper investigation requires a biopsy, but there are ways to exclude the biopsy go for the treatment, go for the markers, look maybe at an MR angiography if the patient is affordable, and then that also can help me in the diagnosis, right? So that's about Raynaud's phenomenon, right? Raynaud's is just an intense vasospasm. If the finger tip has an intense vasospasm, first it becomes pale. That's a routine thing in Raynaud's, right? So what happens in Raynaud's is, because of the intense vasospasm, first it becomes pale because of vasospasm. If we take a finger or a toe or a ear tip or a nose, then it will be followed by a little bit time of redness. Okay. Then you might have cyanosis. Because once there is an intense vasospasm, little bit of collateral supply will try to come, a very brief redness, then nothing goes, no drainage, results in cyanosis. If you want to experience Raynaud's phenomena, right, due to cold, the easiest way for you to experience Raynaud's phenomena is put a rubber band around your fingertip. You can easily experience it. Pale, little bit of your color change will happen. Keep it for a longer time, it will definitely become cyanotic, right? That's the thing in Raynaud's phenomenon. This is how a Raynaud's phenomenon's finger look. It's extremely pale. One of the important thing is, or one of the common thing is, cold can induce it. No one knows the exact phenomenon of Raynaud's, what happens in Raynaud's. Like Mead said, cold is a precipitating factor. Because cold will not cause Raynaud's in every person. Only when the person is already having some problem, it can trigger Raynaud's. It's a precipitating factor. It's not an etiological factor. Definitely a precipitating factor. Emotion is a precipitating factor. Physical trauma is also a precipitating factor. The exact pathogenesis is not known, right? So how we classify Raynaud's phenomenon is, like I said, I can classify it saying it's primary. Generally, we keep all the primaries as idiopathic, or maybe I will pin it on few autoimmune disorders like SLE, a component of SLE, right? And then I do have secondary Raynaud's. When I say secondary Raynaud's phenomenon, in secondary Raynaud's, you can have it secondary to atherosclerosis. If at all I have atherosclerosis of a tiny vessel, which is very unlikely, it can happen. Connective tissue disorder. Systemic sclerosis is one of the important causes of secondary Raynaud's. Lupus is one of the important cause. Myeloma, it can happen. Cold autoimmune hemolytic anemia can happen. Buerger's disease, it can happen, right? Again, the tip is having a less blood supply. That's it, fine. So secondary Raynaud's phenomenon can be due to your TAO, Buerger's disease, can be due to your atherosclerosis, though it is very rare. Can happen in cold autoimmune hemolytic anemia. Can happen in a bunch of syndrome which can be termed as hyperviscosity syndrome, where the blood viscosity is very, very high and the blood becomes very thick and it's not able to perfuse properly. Myeloma, there's lots of immunoglobulin which can make the blood thicker, right? And one of the important cause of secondary Raynaud's is connective tissue disorder, systemic sclerosis. Okay. So these are the causes of Raynaud's, fine. Again, no one knows what's the exact pathogens of Raynaud's. What happens in microscopy, we don't know. We know the classification. There's a definition, not a true vasculitis, it's a functional vasospasm, and the pale redness and cyanosis. That sequence is very, very important for Raynaud's phenomenon. Fine. Okay, that's about Raynaud's. Okay. So I've tried to cover a little bit about your vasculitis, what's required for you. We'll call it a day. I wanted to keep it short and shorter session so that it'll be much useful for you when you start revising. Whatever I'm not covering here, maybe once the entire FARRE is over, I'll maybe try to take 3 or 4 extra sessions. Please ping me what you want in Instagram. I'll definitely try to cover that before university exams, right? The main goal here is to have an approach from the perspective of university exams than to read the entire thing, right? You have the free thing in FARRE. So whenever any topic is put, be it medicine, surgery, your path, pharm or micro, whatever it is, right? Please go and have a look at the book, read them. I'll be definitely covering half of it at least. Rest of the half, when if you want some help, I'll be definitely open to take more classes, fine? See, meet. Let's say that I'll just give you a practical example for us to relate. Pimple, normal pimple. Pimple is a normal problem, right? For some of them, there's a scar formation. For some of them, there'll be blackheads. For some of them, there'll be nothing. It comes, it goes. So pimple is an inflammatory disease. right? It's due to a Propionibacterium acne. So it depends on the intensity. If I'm going to have a very subtle inflammation, body takes care of it. Intima alone is problematic. Like a normal acne, you go and prick it, becomes chronic, forms a scar. So it becomes chronic, it forms a scar, or a very intensely acute, it destroys everything, it involves all the three layers. That's the difference here, right? It's the intensity which causes the change. I hope you can understand that. Okay, great. So see you in the next class. Like I said, for the next class, whatever topic has been put for, be it micro or form, please go through it once in the FARRE book, which is available for you in the MedEd app, and definitely we'll read more things together. Fine. Thank you. Bye bye.